Let's go and start. Hey, dear doctor, this is your mentor, Dr. Sharir, and let's go and start our session today. Today's topic is on GIT. Please mention in the comment section in the beginning from which city or country you are attending this session, actually. And if you are looking forward to your study partner, we have shared a link in our group. So please go there and check out that one. You can also, pitch in Sharia's MC guideline group if you're looking for a study partner, mentioning that you're from our medical academy, and someone might also contact you in that case, actually. Right. While attending the classes, we highly recommend to use a laptop device and using a headphone like this. I usually use simple Logitechs and this, that, you can use that one. All right. So here we go. But from some of the next classes, we'll try to use some different microphone to see that, if you get a little bit more better sounds actually. Okay. So that's I'm working on that one. Yes. Great. Because, Zoom and every software system nowadays, they keep updating things one after another. So let's just see. I mean, if it's about changing a device can be a little bit more better in the sound system actually. Yes. Great. So thank you so much, guys, for joining today's session. Today's first question and today's topic is again GIT. GIT you have done theory very nicely, starting from the esophageal things, then stomach things, some of the colonic things. Actually, we have done very nicely. We mentioned some of the rectal conditions, some of the oral cavity condition will be discussed in the surgery. With that note, let's get started with the very first one. Yes, I hope you can follow. 58-year man, emergency department, and sudden onset of uh, hematemesis, which vomiting fresh blood, and melena. So it looks like probably a upper GIT bleeding, lower GIT bleeding indicating fresh rectal bleeding for past 6 hours actually. Okay, now we have to check the vitals definitely. Heart rate up, blood pressure is going down, saturation is also going down. Looks like. We don't have much info about the liver disease because some liver disease can lead to this kind of conditions like portal conditions. But we have an examination finding with a cool peripheries and delay refilling time. First priority in the step of management. Yes, guys. Okay, a lot of people are answering C, whereas I can also see a lot of people are also answering A at the same time. Some people are choosing B at the same time. I can see that. Please hurry up, guys. It is absolutely important you choose at least a answer. Right. Okay, that is wonderful. Let's get with the answer. Uh, can we add this line by saying like this? Your patient is hemodynamically unstable. Will it be correct statement if I say our patient is hemodynamically unstable? Absolutely yes. Because we have these findings, as you can see. This one, the blood pressure, heart rate, even the oxygen is also. So these are things are getting after. Now, what is the management for any hemodynamically unstable patient? I hope so. Am I right if I'm saying it has always been an IV fluid, IV resuscitation? So IV resuscitation in any hemodynamically unstable patient, actually, right? So this is very, very important. This is very, very important. All right. So acute upper GIT bleeding, you all are agreed on that one. In our case, there was hematemesis and the melena. That was the condition, so which is known as the upper GIT bleeding. With upper GIT bleeding, with hemodynamic instability, so definitely our treatment is IV fluid actually. Now, some of you were also thinking about giving a proton pump inhibitor and this that. Uh, there is a condition bleeding peptic ulcer, but that's a little different one actually. But IV fluid has always been the mainstay. IV fluid has always been the mainstay of the treatments actually. Okay. Moving forward to the next one. There's nothing much to see about the others. Like, some of the question were The other options you really need to understand. I will tell you that one. Here, only one thing I want to highlight, like the option D, start the octiotride. Any idea, any guesses for what cases octiotride is the mainstay of the treatment? If we talk about there is a word something related to lower end of the esophagus, and the lower end of the esophagus related to the some hepatobiliary problem like portal hypertension, portocaval antigen, and there can be bleeding, right? So that bleeding can also lead to like unstable situation. And those cases you might need octiotride. Now, they have clearly mentioned one thing, as you all can see, they have clearly mentioned one thing that this is no known case of liver disease. So do you agree that D is an incorrect answer, right? So if we follow this one, so I think this one would be incorrect actually, because we didn't find the evidences of liver problem. So I don't think so. Octiotrite is a right answer. That's the thing. Great. So moving forward. Happy with the answer? Next question. 36-year-old uh, with a heartburn case. So heartburn case. After meal and night regurgitation, no alarming sign. Maybe no red flag sign of that heartburn condition I'm talking about. What would be the initial management in that particular case? Can you guess it now when I'm saying heartburn after meal and there is night symptom and no alarming sign means red flag sign, which is this condition is about. So first of all, without any further delay, our diagnosis is this is a classic case of GERD. Am I right, guys? This is a very classic case of GERD, a very classic case of DERD. Now, in GERD cases, what is important for you first? Is it a going for a barium? Last day we discussed about this. Or is it going for a trial PPI first? Trial proton pump inhibitor first. Which one do you think is the right thing? Uh, in between these two, this is one of the condition where we start the trial first, actually GERD cases. So we start the trial PPI first. If it doesn't work, then even if we can increase the dose and later we can think about going for a barium testing actually. Okay, here is a John Mutta. If you see John Mutta, we are currently following and referencing John Mutta 9. So in the ninth edition, actually reference would be 451 actually. And here is our symptom like lying down, heartburn, and when you get the real scenario, you might also get the word bloating, water blush, and that particular thing. So John Murtag 451 if you want to double check. And here is your line. That's the proton pump inhibitor trial, proton PPI trial actually. Okay, PPI trial actually. John Murtag 9th, I highly recommend to buy a hard copy. As a large scale institution, we cannot provide you soft copies. Actually, we would be under the copyright strike in that case. All right. So here is a few suggestions for uh, lifestyle related to CERD: avoiding fatty food, reduce the weight, increase fiber slow. Some of the drugs to definitely like anesthesias drugs to avoid. Very, very important using a pillow. So avoid the meal at night, then using a double pillow, avoiding fatty food or excess food might really help in the lifestyle. We also discussed this particular thing, relax lower esophageal sphincter, and for this thing leads to acid reflux, irritation, and there can be so many other complication things can happen. Magnifying this part, yes. If you remember this, esophagitis, Barrett's, anemia, volvulus stricture, all these things can happen, including it can be interrelated with asthma things actually. Moving forward with the next question. All right. Clear? I mean, guys, all good? Please give me signals so that things are well, actually. Okay. 65 year. Okay, one more thing. Please do not try to answer overstepping. When you finish reading the question, only then answer. Otherwise, I'll put you into the waiting room. Okay. So make sure that if you are, if you know well, I mean, it's okay, but that might affect the others actually. Okay. So 45-year-old has epigastric pain and positive urea breath test. What is the next step? Now you can start answering. So next time, do not do that one. I'll put you in the waiting room. Then you cannot see the class. Okay, great. Now it's time so that we can reveal. Now, urea breath test positive. Urea breath test positive. Yes, please. We discussed about it last time. It is urea breath test thing. So in urea breath testing, if it is positive, this is definitely an H. pylori. So we need a H. pylori eradication. Now for H. pylori eradication, what we are gonna do? We are going to use a triple therapy. Okay, so this is that triple therapy we're talking about as per the John Murtagh, page number 455, ninth edition. Ninth edition. Here is your line. Here is your line. A cross question here about this thing. A cross question here about the surgery. We use urea breath test to make a diagnosis. What test we like to do to check if this drug therapy is working well or not? I repeat my question. Triple therapy working well or not? How can I test? The answer, it is the same one, urea breath test. So this is a diagnostic test, and also can we say it's a prognostic test at the same time. So double check that one, guys. Some cases they can give you another thing. Some cases triple therapy fails. Why? Some cases triple therapy fails. Why? It's because some cases metronidazole being used. And metronidazole is a drug like which we have been taking since our childhood sometimes. So metronidazole can be resistant in some cases. Metronidazole can be resistant in some cases actually. So as the clarithromycin as well, as per the new books. Some cases clarithromycin as well, but more with the metronidazole as per the John Murtagh 9. Understand one thing, John Murtagh, we put it as a number one as a reference. Then comes the other things like RACGP, other textbook and this, that actually. Yes. We don't have to read the doses. I think mentioned in the first class, you don't have to read the doses. Yes. There's a lot of drug names are given, like Bisma, the other alternative antibiotics. If you just see John Murtagh 455, you will get to see the alternative names are given. Great. Triple therapy can be extended to quadruple therapy as well, as per the John Murtagh and the regimens. Great. 63-year-old on bupropion, which is definitely an NSAIDs for osteoarthritis. Now he has epigastric pain. Now he has, of course, epigastric pain. The person has epigastric pain and H. pylori negative. Epigastric pain with H. pylori negative. What is the best step? Now, this kind of question MC loves actually, like next step, and they will put you in a situation you can start answering. Now, anything you always have to look into the question is there is anything which is working as a triggering factor or not. Anything which is working as a triggering factor. Now, NSAID, is it possible NSAID induced ulcer? Did we ever learn a topic NSAID induced ulcer in our life? Yes, I think in the last class and then maybe also previously in MBBS that NSAID induced, there is a separate segment, NSAID induced ulcer, and we need to withdraw that one now. So stop that NSAID and start the PPI. Very stop the offending agent. Now, I would like to ask you something here. Can you give a similar example of stop the offending agents? I mean, from asthma, we have learned GIT, or from any other chapter, anyone can give an example. So, stop the offending agent. Anything in your mind? Okay, COPD cases, smoking, very well done. Smoking in COPDs, very well done. And this particular case, NSAIDs in a NSAID induced ulcer. There's another one, Waldenstrom macroglobulinemia. Waldenstrom macroglobulinemia cases, we withdraw the offending antibiotics. Okay, Waldenstrom cases, withdrawing the, yes. Also, yes, even asthma cases, if something is producing more cough, something like, say, if beta blocker or AC inhibitor that is producing some other issues, withdraw the offending agent. Okay. Yeah, last day another one, if you remember, pseudomembranous colitis in the theory class. So if you're giving a drug and that is leading to pseudomembranous colitis like amoxicillin given for, ear infection, amoxicillin in a kid given for ear infection, and then there is diarrhea, and this diarrhea can happen in couple of days, and definitely that one. The cardio one we haven't started yet, but good catch. Toxidase point is there's certain drugs I need to stop. Okay, we will be there in the next week with the cardio. Next one. Okay, 65 year. I'm trying to give more reference from the John Murtagh. Are you guys okay with it? I'm asking you guys. I usually try to use the John Murtagh reference more. Do you guys like it more? It's more difficult to bring that book reference, honestly, because I have to search it actually. Okay, great. Yeah, because we also read that book, so when you get something reference from there, it's more nice actually. Okay. 65 years, so always check the age with the GP. Now, new onset dyspepsia. Now, we started the dyspepsia chapter, the first thing we started in GIT for 2 months. So, long-standing dyspepsia, he reported weight loss, something red flag probably. Now, he has no prior history of peptic ulcer disease, no examination, examination unremarkable. What is the next step in the manual? So, dyspepsia with probably like a weight loss. Is it a red flag for dyspepsia, guys? Red flag for dyspepsia. Now, please choose something. Start your answering. Is it a proton pump inhibitor thing you want to try, or red flag you want to start something? If you remember, similar thing was there for the dysphagia, but even though this is this, so more than 60-year or alarming feature, you need to do urgent endoscopy, which is same thing, the gastroscopy actually. Okay, so here is again the John Murtagh reference I'm showing you here. Red flags, including the unexplained weight loss. Here is our finding. Here is our finding. And if you see the John Murtagh, so investigation of choice is endoscopy. From John Murtagh, 450 page of the dyspepsia. So this is an alarming feature, and we're going for a, yeah. So happy with the answer. It was again from something from the John Murtagh. These all questions are very new questions, guys. Actually, I just module a very new file. Okay, 45-year-old presents with a chronic diarrhea for 6 months. Here is the thing. So diarrhea, remember last day, acute diarrhea, chronic diarrhea, watery diarrhea, bloody diarrhea. Always remember like that. Now found to have a iron deficiency anemia on the blood test. No history of any GI bleed. Very important point. Examination unremarkable. What is the initial investigation? These lines are also, you can start answering now. Initial investigation asking. This is a case given about the chronic, yeah, case. Can anyone tell me what is the diagnosis here? First, chronic diarrhea. Then there is anemia. So chronic diarrhea and the anemia in a 45, so young middle-aged person. Young, see, this is not elderly case. Elderly case, I would have been think maybe it can be cancer or something else, IBD, IBS, and things like that. Now, this is one of the diagnoses can be celiac, one of the diagnoses can be IBS. Now, can it be IBS, guys? I ask you guys question. Can it be IBS, inflammatory bowel syndrome? Can it be IBD, inflammatory bowel disease? If it is inflammatory bowel syndrome, there is a phase of alternative constipation diarrhea, but beyond that one, they will mention that patient will have some mental health issue. Am I right, guys? Saying that IBS cases. I mean, let's be slow now. If IBS, then some mental health issue plus diarrhea and constipation phase separately. And there is in the IBD cases. Now, in IBD cases, blood and the mucus, did they ever mention anywhere about any sort of bleeding? IBD cases can be associated with bleeding, blood and the mucus, right? So, supposed to have blood and the mucus, but we don't see that. So, diarrhea and iron deficiency anemia is the mainstay, looks like actually. Now, what do you think is the final answer? So, final answer, I think it's going more towards the celiac disease. Young middle age is possible celiac disease. So, iron deficiency anemia and chronic diarrhea is strongly suggestive of celiac disease. Do you agree with that point? Okay. Now, let's say it's a celiac disease out of the other options, and now they're asking for an initial investigation. Now, celiac, even though our topic for pediatrics, but last year we mentioned that some question one or two can overlap. So, some of the celiac disease cases, if I want to add the investigation related to celiac disease, anyone knows what is the number one investigation or initial investigation for celiac? Usually, we do the blood test things actually. We can do anti-TTG. There's another one that comes as a next test for celiac cases. Okay, you can say anti-TTG initial. Anti-gliadin, yes. Anti-gliadin, yeah, you can also add that one. What is the best one? How to confirm? This is actually more popular even in the exam. That is the final answer, guys. Final answer is the biopsy one. Final answer is often the biopsy. They mention it as a duodenal biopsy or small bowel biopsy. Okay, so this is for the celiac disease. This is for the celiac disease. Now, even though it's a pediatric topic, guys, do you want me to little bit explain that celiac disease in advance? Is that okay? Okay, we just discussed about the investigation. Let's just come and discuss a little bit about the celiac. Now, um, we have a GIT thing starting from the oral cavity to the anal canal, but anyways, celiac disease is mainly a condition related to which part? Intestinal? Intestinal. Now, talking about the intestine, uh, our intestine has some this thing. What is this thing is called, guys? Which is related to absorption. It's called villi. Okay, everyone understood. Now, suddenly, if you see by biopsy that your villi are kind of like this, if your villi are kind of like this, we call flat villi. Now, do you think flat villi are good? Not really. So if villi are flat, so there will be less absorption. Okay. So mostly the vitamin, mineral, iron, all these things would be affected. And that is one of the reason you get to see iron deficiency anemia. And other than that, many other vitamin and mineral deficiencies. Many other vitamin and the mineral deficiencies you get to see. Now, why this thing happens? Is that an autoimmune disease? Is that a autoimmune disease too? Yes. So autoantibodies are produced. Those autoantibodies worked in the villi against our own body tissues and this that, and then it started to react, right? And we like to use a word intolerance to certain type of food, like means if you take those type of food that will go to the small intestine and they started reacting even more than the other food, started reacting more than the other food. Now what are those food? Barley, rye, oat, wheat. I repeat, barley, rye, oat, and the wheat. Okay, so these are things, and even these ingredients can be present in many other um, food, so you have to be very careful. So Have you seen in Australia, these are very popular in Australia, like in the super shops, that the gluten free. Okay, so have you seen this thing everywhere, even in our countries nowadays? Like there's a special corner. It's a good marketing thing at the same time. It's called the gluten free. Gluten free. Yes, gluten free bread, gluten free jam, gluten free peanut, gluten free this and that actually. Another thing is that another day we discuss the lactose free, right? Lactose free this and that actually. Okay, so the gluten free, the gluten is present in this particular food, and so you need to avoid them actually. Okay. See, I mean, the amount of these days you see, amount of these days, if you see, I mean, it started with a good point, but nowadays the big amount super shop nowadays actually it attracts the client actually. Anything unique, it looks like we got attracted. It's kind of like that. All right. So that's the thing. So gluten free, intolerance to brown. Okay. So you try to avoid. So can we say, even in celiac disease, if you want to give a management, a treatment, what is the first treatment you want to give? So first treatment for this condition is a gluten-free diet. It's a gluten-free diet. Barley, rye, oat, wheat. Lifelong, yes. It has to be lifelong. Unfortunately, autoimmune disease, so it's not going unless if there is a permanent cure. I mean, I don't think so. There's a permanent cure in. So mostly the treatment gluten free. Some extreme cases, you can use this thing, Dapsone. Extreme cases, you can use the Dapsone. Okay. Everyone clear about this celiac disease? By the way, in Australia, there is so many celiac disease and many can be asymptomatic, and later they started to showing symptoms actually. Later they started to showing symptom. Anti TTG is the first line test, then anti-endomysial gliadin as the next, and small bowel biopsy is the main thing. And there would be flattening of the villi, which I have mentioned, confirmatory by small bowel biopsy. Okay. One more, the DD can be lymphoma in some cases. All right. We keep checking the blood test to rule it out. I mean, following up, things is that mostly it's the gluten free. Once diagnosed, you have been always like a celiac, actually. That's the thing. Great. Next one. All right. We have opened a GIT inquiry zone. So someone who is asking that follow-up of the syllabus, please leave that question there. I will come up with a little bit more bigger explanation there actually. Okay. Because some of the parts are not fully always necessary for AMC, but you might have inquiries also about that one. So if you add there, I will be also giving you explanation there more actually. But uh, too much follow-up about the celiac is not much necessary as like the peptic ulcer disease for the AMC. All right. So those kind of questions, please drop it in our GIT inquiries actually. Coming to the next question, man develops epigastric pain shortly after eating in a restaurant with a friend. Past attack of allergy or anaphylaxis after eating carrot cake. By the way, there are a lot of 7-Eleven shops, right? We call it, I think, 7-Eleven. Yeah. So 7-Eleven shops, I think, the petrols and this thing, you can see there are carrot cakes available there. Okay. What is the most likely cause of his current present symptom? Now, let's focus. What do you think? Is it the carrot cake, or is it the gluten, or is it the meal that is causing the problem, or is it carrot? No, first leave the carrot. Nothing to do with the vegetable, we believe. Okay. Now, is it the carrot? Is it the gluten, or is it the egg? Quick question. Is gluten can be very severe, as like and like something like anaphylaxis. So here's a history of anaphylactic shock or something like that. So my question is, gluten can react. But is it possible that gluten can react that much? You understand my point? So not really. Okay. Instead, egg allergy. Understand one thing, egg allergy related, you will find a lot article in AMC actually. So with the egg allergy, I request you guys to search in our group, Sharier's AMC guideline. Very, very important. Sharier's AMC guideline. All right, guys. So it's the egg which is causing it. There's another thing I want to add. Other than the egg, can you tell some other ingredients which is probably also used in cake and can do that kind of reactions? Another one is a very important to remember is nuts. So I have seen also a another variant of a question where uh, something they talk about a cake. In that one, there was nothing mentioned about egg, but there was nut mentioned. And I hope you know nut is something. Nut allergy is a separate section, maybe not given separately in John Murtagh, but in Davidson medicine, there is a separate section is given nut allergy. So a huge number of people are allergic to the nuts, and nuts in our country very limited number of nuts available. But if you go to Australia and many other countries, a lot of variation of the nuts, and usually they you know export this kind of lot of things they usually export. uh, yeah, so many varieties available of nuts actually. So carrot cake mainly contains, and every cake, I mean, how many of you can make cake? I mean, cake, brownie, pastry, just trying to cool down the class, I think. Yeah, I think, what about our male doctors? Yes, as expected, they can eat. Yeah. The basic one I can personally, if you ask me, basic one I can make, but I can cook well actually. But the cake one somehow I don't know. I mean, I didn't try much because probably I don't like cake much actually. Yeah, but on the other hand, I think if it goes in case of any female, they like cake, pastry, cheesecake, and dark chocolate pastries. I think. I mean, we also do like cakes, especially the cheesecake and this that. Yeah, but I think the female like cake a little bit more than the male. I think generally. I think what I have seen actually. All right. Instead, I think we like coffee some cases more actually, especially, I mean, especially if we go to any pastry shop or something like that. Most cases, we sometimes probably prefer a coffee instead of a pastry. And I think if there are with your maybe girlfriend, wife, or anyone is there, in that case, they usually prefer a pastry probably. Anyways, okay, someone is sending pastry. Yes. Yeah. There's nothing very diet thing about the pastry. They can give you a lot of options like sugar free and this, that, but yet well, any proper cake, cheesecake, and this, that, even if we use, uh, sweeteners, but yet the calorie value is so high. Okay, so here is a small tip. Whenever you eat, I mean, if you are into diet or losing some weight or make a balance, I mean, count your calorie. You can eat cake, pastry, all those things sometimes, but just count the calories actually. Go to one eat before class. Okay, good. Or maybe during the break. Okay, little bit extra because this question comes so often. Urticaria or the angioedema related. And please take note that I will teach you this one again separately. But urticaria, angioedema separately very, very important for us because allergy related anything in AMC, I mentioned earlier, allergy related anything in AMC is so important. Maybe in this batch, I'll try to make a separate file someday. and put it into a SMA note as like all the allergy conditions together actually. All right. Now you can see the allergy or the angioedema things can be mild, moderate, and the severe. Okay. Mild cases just mild, allergy. Moderate cases, it is start in the whole body. Yeah. But how do we understand if it is severe? I repeat my question. How do you understand if it is a severe one? Okay. So severe cases of anaphylaxis, angioedema, we understand if there is a wheeze or involvement, wheeze or respiratory involvement, that patient is struggling to take breath. Okay, so this is the one related to severe. Now, normally mild to moderate, like you can use antihistamine, you can use probably prednisolone in moderate cases, but severe cases, my dear, you need to use IM adrenaline. Severe cases, you need to use IM adrenaline. Very, very popular, in the main exam. IM adrenaline. Next question. A 52-year-old patient has ongoing epigastric discomfort despite initial treatment and upper GIT endoscopy with no ulcer malignancy esophagitis. There's no alarm feature and basic blood tests are normal. What is the best ongoing management for approach? Yes, a lot of doctors are going very well. And our final answer is this one, preparation. So, uh, the line which I want to add here, a normal gastroscopy, you can say same thing, endoscopy, synonym of endoscopy, with persistent epigastric symptom, with persistent so normal endoscopic finding, but yet there are epigastric symptom. Epigastric symptom, but when you do endoscopy, no such finding. This is high chances, yeah, with a functional dyspepsia. Okay, functional dyspepsia. Again, normal gastroscopy, persistent epigastric symptom, it is high chances of functional dyspepsia. Mostly it is conservative as a treatment, mostly acid suppression by PPI, mainly acid suppression by PPI, and rule out if there is any H. pylori. Okay, then give a H. pylori treatment in that case. Right? All right. Again, that's the question. Are we clear with the question, guys? Are we clear with the questions? Okay, someone asked a nice question. What if dietary thing? See, they asked about best management actually. So then, of course, obviously, you can go for that one more actually. Okay, well done. Next one. A man with a colicky abdominal pain. So see, abdominal pain related, so many questions you can expect. Next day, we'll go to the cardiology and you'll see so many questions with the chest pain. Okay. In advance, if you can study a little bit chest pain, will be much better, actually. I mean, so Friday we'll upload the overview. If you can at least read the chest pain section from the John Murtagh or anywhere from the SMA note, I think it will be very easy for you in the class. Man with a colicky, abdominal pain, diarrhea, nausea, vomiting, and 4 days following pancreatitis. Now, interesting question. So this is following a surgery. Now, this is, I will say, a little difficult question. So following a major surgery, pancreatitis, like a huge surgery, right? Now, what do you expect? 4 days following surgery, are we expecting obstruction most cases? Possible. But did they mention any word abdominal distension? I haven't teach you guys intestinal obstruction yet, but surgery class I will definitely. But isn't it this line? is important, or the vital signs are also more important, even though vitals they didn't mention. So looks like vitally maybe the patient is fine. But isn't it very important that for any obstruction cases, abdominal distension, please correct me if I'm wrong, abdominal pain and abdominal distension, that is the way to think about any intestinal obstruction, perforation, and all these things actually. Then the sequence coming is, doing an X-ray and looking for a X-ray finding, CT finding after that. Now, since abdominal distension, the main one is not there, I don't think so. It's the intestinal obstruction. Is it clear to everyone why I'm thinking this is probably not an intestinal obstruction? Okay, we understood. Okay, now we are going this thing for, there's a word, gastroparesis. Gastroparesis. Now, what is that gastroparesis thing? It is kind of like a nothing but a stomach paralysis. Sometimes, often we call it like a stomach paralysis. Often they can have diabetes, can be a common cause. Like naturally, it can happen because of diabetes, so long-standing diabetes. And second, another thing is a post-surgical. If we go back to our question, pancreatitis. So this is the surgery that we have done. So post-surgical. So most commonly 4 days following a surgery, this is a very common thing for. Yes, this is a very common thing actually. So we also didn't go for distal obstruction, already mentioned, no abdominal distension. So yes, so our final answer again, gastroparesis actually. They can also change the question. They can give you the same one and they can change the option as ABC and asking about the investigation, right investigation to make a diagnosis. Now tell me which investigation you look forward for gastroparesis. So of course, initially we'll be doing an X-ray as like the basic for any GIT things. We'll be doing an X-ray as an initial. But what would be an appropriate investigation here? So tell me the appropriate investigation for gastroparesis. So which is mentioned in the next one, as you can see, scintigraphy. Maybe this is new for you. I didn't mention about that one in the uh, last class because this is a little exceptional one actually. So scintigraphy, this one. You can do a little bit more research on that one. It's a new topic probably, so you don't have to worry much about that. Moving forward. Okay, I'll hold here for a few seconds. Moving forward to the next one. Always remember, for important disease, the risk factors are important. Which of the following has the greatest impact on development of esophageal cancer? Interesting question. All of them can be, frankly, risk factors, but one of them is more. Certainly, your mind will go for smoking, but smoking is a general thing. And is smoking is more dangerous or something which is a pre-malignant condition already, means already it crossed a step already, is more dangerous. So certainly, Barrett's esophagus is known as a just before the malignancy. That means pre-malignant condition. This is even more dangerous for than smoking because it's already one step ahead because it's a pre-malignant condition. It's a pre-malignant condition. So C. Barrett's can be dangerous. So old age, then these Barrett's, these all things can be dangerous. See, tobacco is not as dangerous as that. Even it's dangerous, but yeah, family history is important. As you can see, ZERD is also there. You see, someone mentioned ZERD, correct, but Barrett's, I like to put a little bit more. Old age again more, may also be important. Yes. So Barrett's esophagus, there can be another AMC question can be asked regarding the Barrett's. That one is how persistently you would like to do endoscopy. Previous, I think, year there was a question was there. I think this year we have removed from this batch. So I at least kept that slide actually. So 2 yearly endoscopy actually. 2 yearly endoscopy. We'll provide a question bank, I mean, which is ready-made we have. So don't worry, you can read that one. Yes. If you want to buy more, I mean, that's totally up to your budget. You can go and buy any subscription by yourself. That's okay. But we'll provide a one very soon, actually. One thing about the question bank, no, nothing is recommended in that way. Any one question bank is fine. I saw all of them. It's you are not getting common from that one. Okay. Especially the last one, someone mentioned, like e-medi, it's too big, first of all, actually. Now, tell me one thing, if you are reading 5 to 6,000 questions, does it makes much sense, honestly? It means I'm including every single topic of the universe. 5 to 6,000. Imagine. Now, 5 to 6,000, I mean, this year, those past, I asked how many you read. So, sir, I read only 1,000 to 1,500. Yeah. So, they are good. The thing is, 5 to 6,000 is way too much, my dear. So, they still haven't um, figuring out yet, like the one that is more important. Like in the classes, the way we go, like we target the important one in this time. So that one is probably used like generally topics are taken and generally question have been made. Now it is much more easy. Also, there is AI and many other things. It's quite an easy making those things actually. So I won't give much credit. Good question bank, but if you're thinking you will get so many things common, you have to study 6,000 questions and remember it probably, but yet chances we don't know. All right. Amedics is so far good. I mean, I directly don't recommend anyone, but a lot of our students also studied Amedics since till date actually. So every time this happens, a new question bank came up. They are up to that. There was influx came as well. I think some people are also up to that one. So here is my suggestion. Target only one question bank. Do not go like someone said this, someone said this. Question bank will not, from question banks, you will not get so many questions actually. Unless the important topics are there, automatically important. Say pulmonary embolism is important topic, Barrett's is an important topic. So those topics automatically will come. It doesn't mean that they are just only providing the important ones. It's not like that. You understand everyone? Question bank. Question bank is good for your self practice, time mode practice this. So time mode practice can be good if you take subscriptions actually, time mode practices actually. Okay, great. In MC, you know what more important, having a good study group with 2 to 3 people's study group. They stay together till the exam and finish everything, every important recall, previous recall, class contents. I can tell from experience. Some I mean, one time we used to study, then, I started taking classes since 9, 10 years. That is something most important, actually, that, stick together with 2 to 3 people. And, whatever the contents are, you are different, man, like everyone is giving everything. Don't hide things from your friends, for God's sake. There's almost some people has this habit that, okay, I'll not tell my friend these things. It's like the kindergarten, attitude. Yeah, I mean, whatever knowledge is for sharing. Yeah, I always tell this thing in the class. If you share your knowledge, it will not decrease. Instead, it can increase. Always remember this line. Yeah. So if you share knowledge, it will not decrease in any way, actually. So give your wholehearted things. It will come back to you in more double way, always, actually. You can and keep explaining. Your vocal would be good for MC2 at the same time. So if you can speak well, give a demo to your friends, actually. Yeah, it will be nice. Yes. Great. All right. After this slide, I'll show you some radiology if you're more interested. All the important relevant radiologies I would like to show after this slide. So here is the one radiology, with complaining of dysphagia to ligate, asking about a definitive management. This kind of question we have finished. So first a diagnosis, then a treatment. This is kind of like a rat tail or bird breed, whatever you say. And it's a definitive management breed because best management they are asking. So best management is always been I think it should be the surgery one. So it should be the surgery one. It's the best management. Okay. And diagnosis is going for the achalasia. Diagnosis is mostly achalasia. Yes. Now, will you be interested more if I show you some of the uh, barium pictures? Will you be interested on that one? Because sometimes some barium pictures are given. So a little bit, let's go for some barium testing. Going to share. Here we go. Now this is fastest finger first. Let's see who can go first. Time is up. Time is going up. You don't have that kind of time in MC. Ah, not bad. Yes, you don't need to mention that. That's a hiatus hernia. Some part is going there, so it's hiatus. What about this one? So about this one, this one is like actually you'll take the this part. This is more towards the achalasia. See, sometimes always the very classic one, this section they might not give you. So this is a achalasia. Okay. So taking a second. Okay. What about this? This one I think easy. The classic bird beak. Previous one was not classic, but this one is quite a classic. Bird beak appearance is again an achalasia. All right. What about this one? Is there some sort of filling effect? Some sort of filling effect. This is like a cancer. And here is one with the esophageal web because there was a web was given. So this one is a esophageal webbing. Uh, this one is not necessary for you guys. Again, a filling defect. It's for the cancer. Previous one is a filling defect. It's like a cancer. What about this one, guys? What about this one? So again, that one is a hiatus hernia. See some part getting above the level. So it's again hiatus hernia. Last one of today. This one is probably more important. So the one is the achalasia and this one. These two are more important for the exam. Okay. So this one is corkscrew appearance. So this one is going to esophageal spasm. Tell me one thing quickly. If it's anything is a esophageal spasm, what is your management for that? Esophageal, yeah, this is a classic esophageal spasm, corkscrew appearance. So management for that one is a CCB or calcium channel blocker or nitroglycerin. Also, all you can do, some cases, dilatation you can do too. Because there are some parts are constricted, so dilatation can be applied to. Okay. One more thing, as a suggestion that question came one time, that is avoid extreme cold. Okay, so try avoid the extreme cold or extreme heat. So that's important. So everyone, are we clear about the spasm thing? So everyone, are we clear about the spasm related thing? Okay. So corkscrew appearance and try to avoid extreme cold or extreme heat. Great. Next one. So 65-year-old with iron deficiency anemia, FOBT positive, very important, upper GIT endoscopy is normal, and colonoscopy could not be advanced beyond hepatic flexure. You know, in our intestine, there are two flexures. One is a splenic flexor, one is a hepatic flexure. So far, whatever visualized, the mucosa is normal, is stable. What is the next best step in the investigation? This type of questions are so common in MC. So you cannot proceed with the colonoscopy. You are not really sure. In that case, actually, all you can go for a capsule, guys. Capsule endoscopy, very popular in MC. Very, very popular. Capsule endoscopy. So when endoscopy or colonoscopic findings you're not sure, you go for capsule endoscopy. Fun fact here, this is a small capsule. It's given, and as a patient has to return that one actually. As a patient has to return that one. Okay, someone asks, what is the diagnosis? What is the exact diagnosis is tough to tell at this point. So you need to rule out the cause of the bleeding. It can be because of C65 years, it can be cancer, it can be some other causes of bleeding. That is why you need the endoscopy actually in this point. Okay. So we do this test to rule out the exact condition actually. Okay. But you can suspect actually. Yeah. You can suspect actually. So because HC obscure bleeding, you can also rule out if it can be IBD because IBD can be leads to bleeding. So find out the points of bleeding, find out the point of the ulcers, assessment of celiac, screening and surveillance for FAP, colon cancer. Okay, so these all things you can rule out by doing the, yeah, great. If you do CT, you cannot rule out those things so easily. Okay. First, you need to be sure with, like, because anything, cancerous, you need to rule that one first, actually. So, right. All right. So, here is a line to remember. Few things are as like a protocol, like when endoscopy or colonoscopy fails, it is capsule endoscopy. Okay. So, that's the rule, actually. It's not about always going for CT and this, that. Uh, when endoscopy colonoscopy fails, you send capsule endoscopy. Check those particular parts because you cannot send your device to those particular parts actually, right? Good. Clear now, everyone? The part which you cannot see with endoscopy, colonoscopy, you send capsule endoscopy there. Okay. So obscure GI bleeding, bleeding source not found on endoscopy, colonoscopy, you send capsule endoscopy. As a patient, you have to return that capsule. Well done. 58-year-old man with a history of gastric cancer and parietal gastrectomy now reports that 1 hour after meal, he develops some symptoms. These are his symptoms after a meal. And as a previous history, he has this special history, which makes to make a diagnosis easy. What is the likely diagnosis? Start your answer. So answer is a so within 1 hour after meal, he is developing these symptoms. So the diagnosis is going more towards the diagnosis is more going more towards the because it is within a 1 hour. So it is early dumping syndrome. So it is going more towards the early dumping syndrome. Okay. And often they have a history of gastrectomy. Some part of the gut is gone actually. So dumping syndrome is quite a common. So early dumping syndrome, when they eat and they will have certain symptoms like nausea, vomiting, sweating, lightheadedness. These are quite a common actually. With the word confusion and these things are more common in a late dumping syndrome. Now, anything would you like to uh, give as a suggestion? Yes, dietary modification and smaller meals actually. I'll give you an example of dumping syndrome. We all probably had felt Down syndrome in our life. How? Now, uh, how many of you can still eat a lot? I mean, even though it looks like a lame question, but some of you still have the capacity. It's not up to 30 minutes, up to first 1 hour is dumping, but the symptoms more in 15 to 30 minutes. But up to 1 hour, we call it dumping. Okay, I think this one now he reports that about 1 hour after meal. Okay, sorry, I think it's a late dumping. I'm sorry, guys. Yeah, yeah. So I mark it. Thank you, my dear. It should be late dumping, my dear. Sorry, my bad. I was telling it's correct. Now it's mentioned 1 hour after meal. Exactly. Yeah. So in our case, it's mentioned 1 hour after meal. So 1 hour after meal is going towards the late dumpings. Symptoms are uh, kind of moreover almost similar actually. Symptoms are all moreover similar. Even treatments are moreover similar, like dietary adjustment, modification, smaller meals. Smaller meals. Do you prefer simple carb or do you prefer complex carb for them? Interesting, right? Would you prefer simple carb or complex carb? Okay. See, if you give them complex carb, it will stay in the stomach for longer time. Perhaps complex carb are not absorbed very fast actually, and it will stay in the stomach for longer time. Now, is it a good thing? Will it aggravate the symptom if it stays? So answer it will if it stays, it will aggravate. So I think we prefer the smaller meal and simple carbs for them actually. Okay, so that they can absorb it. Yeah, but in as long as they have more food in their tummy, it's troublesome. Now I was talking about something, an example we all probably had felt dumping syndrome. Early days, imagine our internship days, we used to have so many offer from the pharmaceutical companies as invitation and this that. Now we used to go because those are free foods kind of, and we had a certain type of joy. Please let me know in the comment section, if you can correlate with that one actually. And somehow we used to eat a lot actually. Even with the girls with us, they used to also eat a lot actually. That time I don't know from where a lot energy come in everyone. Yeah, I think so. We miss those days sometimes. I don't know. Um, this is how the things are about life actually. At some point, you probably look forward to eat, and at some point, even you have everything, but you probably can't eat as the way you want to, right? Yeah. So that time I used to pray, oh, I wish I get invitation, a marriage ceremony invitation, or a internship days, a pharmaceutical things. Yeah, this, that. Now I think so many people, will call you for buffet lunch, this, that, even friends calling it. And that time thing happened, whoever going, and no one wants to put their money that particular time actually from their pocket. Now when you go with our friends, and it's like everyone is up to open his wallet. So that's the difference of life actually. At that time no one wants to bring anything from the pocket actually, and everyone looking forward to the free food. So that dumping syndrome feeling, I think we have felt. I mean, when we eat like two plates, when you eat like two plates, and two Coca-Cola and this, that, it's already, that feeling is kind of like a dumping feeling actually. So we all probably have felt actually at some point actually. Yes. I'd like to introduce you guys to another good website. You can double check. Its name is MedBullet. Okay. So MedBullet also has certain good clinical veganity. You can also search the dumping syndrome in MedBullet. Actually, there's a website. I'll give you a demonstration of that website someday, but it's a very nice one. The MedBullet. You can double check that. Actually, next one. A 65-year-old presents with again epigastric pain and burning sensation for several weeks, no vomiting and GI bleeding. In urea breath test is H. pylori negative. Okay, negative. Okay. Now, what is the and you start him in omeprazole. What is the next step in the management? H. pylori negative, guys. So basically, it's more like H. pylori negative case. It's not because of H. pylori. So I think why this burning cessation? Why still is this pain? We keep it under observation. Yeah. So we like to do a test probably after a few days. Yes. So our correct answer would be here. Going for a upper GIT endoscopy after 6 weeks, upper GIT endoscopy after 6 weeks. So it's more of like a follow-up question. So peptic ulcer disease related follow-up questions are important. Maybe you can also check with the esophageal follow-up questions like this. Next question. A young patient with a progressive dysphagia. Okay, if I ask you this word, progressive dysphagia, is it fast or is it slow dysphagia? Young patient with progressive dysphagia, gradual, okay, like moderate. He was treated with omeprazole and the symptom haven't or didn't improved. On examination, is erythema of the throat and investigation suggests narrow esophagus. Now that's a good finding. A provisional diagnosis is severe. Okay, they already mentioned what is the most appropriate step. So ZRD related complication it can be. So what do you think? What we should go with? There it has been given PPI. Now here is that line I think I mentioned last day. Uh, yeah, I think I would like to go for that one. Here is a little bit confusion. Let us focus on this question. Young patient with progressive dysphagia, omeprazole really, but his symptom didn't improve. These things are there, and investigation. I think gastroscopy is done and showing the narrow esophagus. So I think it's like a, if you already with narrow esophagus and this, then a provisional diagnosis of a severe GERD. Yeah. So I think if it is a severe GERD already established, I think it's better to go with a increased dose of the PPI. Right. I think classic answer is this one as per the John Murtak concern. I'll take you to that John Murtak part just to show you again. But I hope you guys understand, right? Like normally we try the PPI. So ZERD, here's the ZERD, page number 452. So here is initially stage one, some dietary advice. Then in a stage two, we bring the drug. So PPI, something 20 milligram of PPI for 4 weeks. Okay. And then, see 40 milligram PPI, 40 milligram. Here is the thing. This is a very classic question too for the exam. This is one of the classic question too for the exam. I just took up the screen. Let me just bring that point. John Murtagh 453 page, guys. Just bringing that thing. So maybe we can put this under GERD, step up management. Do you agree, guys? We can put this more under the GERD, step up management. Yes, sharing the screen now again. So 453, as you all can see, 40 GERD, step up management. I think that particular line is little, um, I think, misleading. Maybe the upper part is narrow, the lower part is up to be relaxed, actually, in my opinion. I think we are taking this particular line, like severe GERD is considered. Usually there is, we don't also think narrow esophagus is that appropriate line for that, actually. But all other particular condition is in probably indicating towards the GIT. So sometimes in question, because these are recall questions, so sometimes we don't uh, really sure that what particular finding has been given. So their findings can be misleading some cases. We know what is the finding of GID. GID normal finding is a lax sphincter. It can be as a chance. Narrow esophagus is not really. There is another option. Someone is mentioning eosinophilic esophagitis, but there will be very clear view with particular type of food will be mentioned. Very nice catch, but there will be particular type of food will be always been mentioned about that one. And in eosinophilic esophagitis cases, there will be multiple, constrictions. That's the exact word for that. Okay. It's a good DD what you're thinking, but I think it's not correct actually. Uh, Here is the main thing is that actually I think they mentioned about severe ZRD. All I can understand, maybe the recaller has made a mistake while collecting that, he thought that narrow maybe esophagus actually he saw, some cases, but maybe it was a lower esophageal sphincter relaxed actually. Yeah. Or maybe upper part is a bit thin, lower part is bit lack. So you may be misinterpreted that. So Nicholas thinks we always assume as a hypothetically. Okay. Mm, great. If you have any further question related to ZERD, feel free to ask me in our inquiry zone of the ZERD. I'll get back to you there actually. So I think some people trying to ask question. You can copy this one. And there is our inquiry zone. Please go to our GIT inquiry zone and feel free to drop that question there. All right. Right. No one asked any single question. I'm just putting a hi in there in that CIT inquiry zone so that you guys ask one, two questions. Very important, guys. You do ask me questions in our Facebook group, that inquiry zone of that live batch, so that we know we can answer you back, and everyone can see that later. Great. Coming back to this one. A 55-year-old truck driver presents abdominal bloating, pain, and chronic diarrhea for 3 months. He has no weight loss or GI bleed. Colonoscopy is performed. 1 year ago was normal. What is the most appropriate next step in the investigation? So, guys, I mean, I would also recommend one, two people in future you can take as a class monitor. So they can also copy some of the questions which you feel is important from here, and you can also post those things showing your activeness. Trust me, with the class monitor, I stay very much connected for a very long time, actually. Yes. So those some of the questions you are getting here, you can also collect them, and maybe you can, instead of them, you can post those questions later, actually. Okay, wonderful. Okay, so this question is related to a profession, looks like more to me, because truck driver with some, I would say, GIT features, right? And this is chronic. So can I say this is kind of like a chronic diarrhea? Yes. A chronic diarrhea, there can be some of the other disease. Is it possible chronic diarrhea can be parasitic, especially in a cases like truck driver? Yes, definitely it is. So we'll go for a stool examination for ova and cyst to probably rule out what can be the cause. So probably to rule out what can be the cause actually. So let's go here, finding out. Yeah. So occupation truck driver, diarrhea more than 3 months, suggesting chronic diarrhea. So high chances para parasite. So it is possibility to have this one can be Giardia. And one more thing in AMC, Giardia is definitely tested a lot. Giardia related things are tested a lot in the main exam. Okay. Giardia is nothing but, it's like a badminton shaped parasite and this, that. And it usually presents with a state urea, more chances. So stool which floats on the toilet, greasy stool. These are more of the common features. These can be more of the common features. So here we have few points: abdominal bloating, pain, and the chronic diarrhea things are given. Very important information: no weight loss and GI bleeding. Okay, so that will rule out a lot of things like celiac, like cancer, like many other things. Colonoscopy was done 1 year ago, which was totally fine, passed. Subtribute next because it's a track. It's better to rule out um, this particular thing, ZRTR. Mhm. Usually, it's a good point. Someone is saying, why not HIV at first? See, HIV first thing, would be like fatigue, weakness. Okay. So those particular words will be there, and at the same time, weight loss too. Then it depends on the CD4 count, the other, super infection. Like if they're having chronic candida, repeatedly they're having candida problem, then it can be sign the patient is immune suppressed. Okay. So those kind of hints supposed to be there. I mean to say, um, like a immunocompromised features. Also depends on the CD4 count. Some of the other super infections are more expected for HIV, even though it's a very good DD of this particular thing. Yeah, occupation was truck driver is very much towards the HIV, highly high chances. But so as the parasitic infections too, because they go from here to there, then the very remote area where they're eating different things. So it's a possibility to get the ZRD in these cases. Because living in Australian central cities, you will not get ZRD, but when you are taking your truck to very rural areas, then there is possibility of ZRD. Right. Now, a young person having increased vomiting in past 3 days and has been gaining weight previously, but now not gaining weight. The child is cheerful and happy, but not dehydrated. So, what is the most likely the diagnosis actually? Oh, interesting question. So, even after vomiting and this, that the child seems cheerful and fine, and it's vomiting things are there. So, I think this is going more towards the, I think ZERD, going more towards the, I think ZERD. It is more evident. Okay. Now, why not pyloric stenosis? Now, it's a lot of things. In case of pyloric stenosis, now let me ask you a cross question. After vomiting, feeling lethargic, indicating what? After vomiting, feeling lethargic, this is an indicator of what? Okay, we do. So we learn more in John Mutak, I mean in pediatrics. So we will expect few things: projected vomiting, acute weight loss. Yeah. Also, if you do more tests, like you will find alkalosis and these things in case of pyloric stenosis. Caterpillar sign. It's interesting picture. One more thing to remember, um, there's another similar condition, more common in adults, of course, the gastric outlet obstruction, the similar vomiting features and just that non-bilious vomiting, projectile vomiting. So these are common there in gastric outlet obstruction, but there is a special line for gastric outlet obstruction. Vomiting may be intermediate and usually 1 hour of meal. Okay, so this line, please mark. It used to be a question in past, I think. In previously, we used to teach that one. We removed that one uh, as a question because no longer it's coming more. But vomiting may be intermediate and usually occurs within 1 hour of meal. Okay, this is important. So these extra little things maybe we can. Sorry for taking time. Okay. So it's always been very popular, GERD versus PS. I'll try to add a slide afterwards, maybe after class, or someone can ask me in the inquiries, and doctor, can you tell me the differences between GERD and the PS? I can tell you so many other differences. Why we probably will have chart of that one actually. Right. So here is the thing for pyloric stenosis, projectile vomiting expected more, um, alkalosis. These are the things. Child stays more, you know, becomes more lethargic after the incidents in PS. One more thing, there is a olive mass. Is it possible? Olive shaped mass in case of pyloric stenosis? Yes, this is another important physical examination finding that we're having because stenosis. So when we examine, we feel there is a mass. It's not 100% always, but many cases of pyloric stenosis, you can expect some olive mass. We have seen that one in some of the questions. Okay, so ZIT related we have discussed, so we are not going there. Moving to the next one. After two more questions, we'll go for a break. Young man presents with a mixed stool. Your keyword is here. It's a mixed type of stool and it is young, not one similar episode 3 months ago, now say again another episode. So multiple episodes we can say. Reports unintentional weight loss. Now this is interesting. History of travel 2 years ago. What is the likely diagnosis? Interesting question. Come on, guys. So there's a history of travel long back. Mucus mixed with stool, weight loss. So it's a close one. Now, some people are answering C. So please check the age group. It is young. So it is first of all less likely. Okay, with a colon cancer. I'm not saying it can't be happen, but they didn't mention about family history. So less likely unless family history. Up to this clear, everyone? I mean, if colon cancer, they will be mentioning about family history. If it's a young person developing colon cancer, definitely family history in a form of FAP or age in PCC type will be mentioned. Yeah. Giardia, just while ago, we learned chronic diarrhea. Chronic diarrhea thing will be mentioned. Occupation will be mentioned, or they will be mentioned like aborigines. Aborigine kids often living in a different areas in Australia, then they can have this thing because of lack of hygiene and this that. So this one is also not the answer, I think. So this is our chronic amoebic colitis. This is one, and then there is a ulcerative colitis. So we have these two in between. Okay, so let's think for a few seconds because both of them are very close answers. Mucus in the stool, you always give a double thing for IBD, definitely. Yes, as someone mentioned also, blood, you may not always get the blood actually. Yes. One more thing, if this would have been answer, it would supposed to be more recent. Uh, that's what we expect. See, ulcerative colitis or IBD, how you guys think it's actually a very big topic. IBD has so many types. Does anyone know types? Because in John Mutta, they have written this thing very short. Certainly, IBD, we know ulcerative colitis, Crohn's disease. There are a few things like a very active type, like um, if you, I recommend you to check the Davidson's medicine for, I think, to know more about the IBDs actually. Yes. Yeah, they will be asking. See, uh, first of all, blood, mucus mixed with stool. That's like a very and young person, very clear view, certainly to think about IBD. I mean, even if you ask us as a like consultant, as a clinician, like someone presents with mucus, we always do think about the IBD. That's how it's because the blood is not always the visible thing. About the weight loss, because see, this weight loss is not like a cancer in IBD cases. Actually, I don't know how many IBD you have seen in your life. But when a patient is having, say, ulcerative colitis, they have ulcers. So when you have ulcer, you have pain. So when you eat, and if there is an acute flare up, when you eat, they feel pain at the same time because of ulcers and this that. Because by name it's ulcerative colitis. So automatically the total eating number of meal or amount of food has been reduced. So they start losing weight when there is an acute flare up. So in that way, you can explain the weight loss particularly. Speaking about the blood thing can come over the time actually. It's not like always, I know it's classic, but the way simply you guys are thinking, this is the, I think, most biggest chapter in Davidson's medicine. Am I right, guys? How many of you studied the Davidson here? I'm sure many of you. But in Davidson, this is probably one of the largest, one of the disease that has been discussed, right? Including mentioning about the types and many other things actually. So IBD there are colitis type. IBD there are like unclassified types. So many other things have been always there actually. Okay, so you cannot directly put in that way. Okay, it's blood 100% always. It's not necessary. It's just going with the young mucus mixed with stew. Blood can be present over the time if it is not present. um, yeah, I think it going forward, I think ulcerative colitis more maybe, in my opinion, actually. And I think when you go for the exam, I think because it's a recall, they will tell you more things. One more thing I wanted to highlight here. This happened 6 months ago in past, and the second episode now. So it's like a recurrence. Am I right? Recurrence or episodic. So is this thing common in amoebic colitis? Not really, right? So this recurrence and remission, these particular things are also common in case of ulcerative colitis, right? So I think ulcerative colitis diagnosis is not a um, usually, we don't expect MBBS doctors to make a diagnosis of ulcerative colitis, honestly speaking, actually. Usually, it is recommended to refer when you suspect something. Okay. So, because in MC exam is mostly designed so that you can at least suspect these things. They usually don't expect you to make a very clear diagnosis this that. So, this is one of the question is more, I would say, related to practical experience. Those of you have practiced well, I'm sure you all are getting a clear view from your clinical experience, as like I do have. So I can see like relevant feature to go for a diagnosis because later, we make confirmatory tests to clear it. Am I right? But initially, you cannot miss a diagnosis. All you can do is suspect actually. Yeah. So my suspicion goes with the ulcerative colitis. Is it clear now, the explanation? I think when you go to the main exam, they might give you one, two more features. Like there was a question previously there, because which probably have the repeller missed it, that there's an area of friable mucosa, something was mentioned. So normally the level of AMC is more like a GP doctor's level, but this question is more like a consultant base. So in order to make it like a GP level or MBBS level question, they are usually supposed to give you an examination finding or some sort of finding. Because I've been experienced with AMC teaching, so previously I've seen a question. They mentioned that there was a 10 centimeter friable mucosa. That word was mentioned actually. Okay, 10 centimeter friable mucosa was mentioned in one of the question, which is again a key thing for the ulcerative colitis. Okay, so my opinion, this question looks okay, but there was nothing mentioned about a special finding. So when you have that special finding in the exam, I think your shot would be more easy actually. Otherwise, it's more like a consultant level question, which usually they don't ask in MC, right? Uh, Now, this is the ulcerative colitis and the Crohn's disease. Because it's an important disease, I would highly recommend check from the Davidson's medicine one time, the IBD. Okay, because the question keep coming from that part. So I want to you guys to get a little out of from the uh, John Murtak here because very small portion has been discussed, but originally very big disease. That particular thing when you go to the Davidson's medicine or other books. Is it clear, everyone? So IBD, study more from the Davidson or other books. Clear? Coming to this one, this particular things I just discussed a little bit. And here is your special another line. Area of Fraggle. See, area of Fraggle. Right. So they mentioned here as a ulcerative colitis, maybe it can be IBD. IBD also related to Crohn's actually. So I'm just assuming all hypothetical things here. As together, they we think they are IBD. So there's a lot of form of IBD, ulcerative colitis, Crohn's disease. See, the bleeding occurs only with the colon. Somewhere they have mentioned. Okay, whereas classic IBD cases, we are expecting bloody diarrhea and the mucus. Here's a little bit about the IBD. Have a look. Try to recollect from the whatever you read in the journal method. Okay, so we usually start with as sulfasalazine, very important. There is a flare-up case, so corticosteroid in the case treatment failure cases as a therapy. In between, you can also use the MTX if needed. So, key diagnostic features for ulcerative colitis. I knew that this question might suffer you. Recurrent episode, in our case, it was mentioned. mucus, plus minus blood in the stool. You see this? These are the diagnostic features. Then there'll be weight loss thing. Also, the travel history you are trying to pick up here is too long for ambiculitis. Also, young age supporting the IBD as well. Now clear, everyone? Please comment in the comment section so that we can move to the. We took a little bit more time as requested, and make sure you guys done and dusted later all IBD things, because half of you will get one question regarding the IBD. Now, another tricky question. See, this is like MC exam. As the question progresses in the main hall, it's get tougher and tougher. Started like easy peasy, middle part, some tough questions started to come. Same things are happening here. Middle-aged man, history of surgery for achalasia a few years ago, presents with hoarseness of the voice for 1 month, dysphagia for 2 weeks. On examination, vocal cord paralysis noticed, revealing a mass, likely diagnosis. What do you think? All right. So I think more people prefer this one, cancer of the esophagus. Okay. Oops, something has happened. Now, this is called like a bamboo therapy by the AMC. Think me like an MC examiner. I know I'll be always up to something bash or bamboo therapy, whatever you say. So here, our more early symptom is hoarseness and the prominent symptom. So can we see here hoarseness over dysphagia? Can you say like that? That hoarseness arrives first. Am I right, guys? Hoarseness over dysphagia. 1 month of hoarseness, 15 days of dysphagia. So our diagnosis would be laryngeal, yeah, cancer. To be noted, also vocal cord related things are kept actually. Yes. Yeah, right. So usually we prefer this one since hoarseness is early feature than the dysphagia, than laryngeal cancer. So here is the thing. In order to go with, see, I mean, question bank, we cannot take it as a reference, first of all. If the same question, dysphagia over the hoarseness, then we'll go more with the answer would be esophageal cancer. Now, this question I kept. This question is not a new question. It used to be a controversial question. I kept that one. I consult this one with the ENT doctors as well, and they have also verified. Yes. So this is how the things are actually. Right. So the cancer of the larynx thing. So the cancer of the larynx things. Like if dysphagia thing phase, hoarseness phase is small, we'll go more with that one to the laryngeal actually. So forget about what question bank says this that, because those are usually modeled by medical students most cases. Yeah. So don't always go with their tough one. Definitely do check the textbook references this that. A question bank like MATEX has 5% of the error. Even MPLUX has like 8-9% of error. So you have to correct these things while you study. Okay. Okay. Some information about the esophageal cancer. I'm not going into more details because we have studied esophageal cancer in our previous class. You can check our previous GIT theory video. Yes, for the esophageal cancer, which we have discussed already. Next question. After this question, we'll go for a break. Okay, perianal fistula and escapulation, best induction for moderate flare-up. Okay. Because it's a recall, so just managed to collect the smaller part actually. Sometimes you might ask, like, why it's small, doctor? Because the full version we couldn't get from the recall. So pain firstly is capitulation. So best induction for moderate flare up. First of all, what is your probable diagnosis? Any idea, any guesses, what is the diagnosis? Okay, IBD, well done. I mean, IBD, which one? IBD, you are close. In which IBD? Is the ulcerative colitis of the Crohn's? Stipulation and the fistula. Obstruction, fistula, these things are features of, if you remember, Crohn's disease. Now, IBD can flare up. There can be relapse remittance. So there's moderate flare up situation. If flare up situation, right answer is always prednisone. Am I right? Right answer. Don't get tricked. So flare means acute flare. Always remember that word. Flare means acute flare. Even if I go back to this one, even in IBD, if it's a flare up, steroid. Clear now? Things are tricky, guys. You have to remember my lectures very well, SMA notes very well. Then the extra thing, keep learning, keep learning. There's a word called galvanizing. If you remember from the chemistry, whatever the things you have, okay, on that one, you give more layers, then it become more protective, more stronger. So my classes, my lectures, and this John Murtag and all these things, you have to study and you have to remember at the same time. Then on the top, now you add more things from the question banks, more thing from the recalls, more thing from the forums, like say Sharier's, AMC guideline. If you just type it would come up. So this forum has many recalls. You can use the hashtag, say hashtag GIT. You might find many questions since 2016 to 2025, 25, like almost 10 years. You can keep solving. So the more you will do alongside your theory inside, recall inside, SMA note inside, okay, and then more question bank, more recalls, more forum, you become more stronger, you know, over the time. You become more stronger over the time. Okay, your uh, study partner can help you even more to become more stronger. Okay, today is a Thursday, so we don't have a test. So next Sunday after class, we'll have a test, my dear. Right. So you understand, guys? I can say this is like a key to success. These are like a key to success, actually. Some people, for their safety, they took more subscription, they took more. Uh, Even after other than our 5 months course, there are separate recall courses available where we solve even more separate recalls, because in one of those classes we cannot do uh, that huge recall always actually. So there is month-wise things also available. Yeah. So everything depends, like, how much you are giving effort. Some people don't need any other recall courses. Some people might need it because they are not studying well actually. So here is the thing. So red color, green color, yellow color, and green color as like the traffic light. It's like the traffic light, guys. Okay, isn't it a good example, guys? Yeah. So keep the theory, keep the class recalls, keep the SMA note, and then we do galvanizing. Yeah. Otherwise, you will be if you don't keep this thing, that will be living like a permanent hole. So your enemy can come and destroy you, which is the AMC examiner. AMC examiner. Speaking about the MC examiner, I have a picture of one of the MC examiner. Let me show. Where is that? Okay, I'll show it at the end. I have a nice picture of one of the examiner. I'll show it at the end actually. Very interesting. Okay, so we took this one, Crohn's disease. Yes. Okay, one more and then going to break. Severe pain out of proportion and atrial fibrillation history. Even though a bit surgical question, lactate level is increased. Best test. Severe abdominal pain, you mean to say. Or like epigastric pain, better word. Any idea, any like what can be the diagnosis? Okay, many people went for ultrasound actually in okay. Diagnosis, please. Suicide embolism. TTP. This can be one of the keyword. Uh, yes, it can be an embolic condition, but with that, atrial fibrillation can be history. Atrial fibrillation can be as a history for that one. Dissection will have, my dear, hypertension often as a keyword. The uncontrolled hypertension recent time, previously Marfan disease, those things. So this one, see lactate level increase, atrial fibrillation in the history, severe abdominal pain. If I give you more hint, more pain in the colonic flexure, more pain in the colonic flexure, more pain after eating, more pain after eating. So this is going more towards the uh, mesenteric ischemia, which I haven't taught you guys yet, but abdominal pain is the including part. Anything they can ask, medicine question, surgical question, gynae question. Yeah. So, yeah, CTA is a diagnostic, but yeah. Okay, let us see a few things about the mesenteric ischemia, then we decide the final one actually. If you have a mesenteric ischemia, of course, you can do a radiography on the chest, and there will be thumb printing, some of the appearance expected, right? Now, more tests which will includes like same as the this thing ECG we do because true lateral fibrillation, yet they are the initial ones and the radiological one. And then we go for a CT often actually, CT, and then we think about the CT angiography as a gold standard actually, CT angiography as a gold standard actually. So what do you think? What is the uh, right answer here? I think C should be the right answer here. Do you think? Agreed? Yeah, because they ask about a diagnostic one. So mesenteric ischemia, even if you check John Muttak also has mesenteric ischemia. Let me try to show you a little bit. I'll show you a classic one. So this is how the mesenteric ischemia, these mesenteric arteries are involved. Inferior mesenteric arteries, this part, this splenic, superior mesenteric artery, this particular part. Okay, now you understood. So it's more like a uh, ischemia of the gut, and that leads to like a, it's kind of like a heart attack of the uh, tummy or abdomen, right? Okay. Now this is a classic question. Our one was the one we got was different. This one is like a question bank question. With a 65-year pain and distension 5 days after AMI, already after a thromboembolic manifestation, abdominal pain distension, mildly distended, reduced bowel sound, X-ray showing a small bowel at this level, blood test showing metabolic acidosis actually. So what is the likely diagnosis? Yes. So this one again, a classic for mesenteric ischemia. There is a thromboembolic event was there following this abdominal pain. Also, do you have the uh, X-ray finding things is there? And ABG has been done actually. This ABG and lactate level usually are tested in the beginning. Okay, great. So is it clear, everyone? This particular one is clear. Please confirm in the comment section. I'll guide you more in coming days. I'll guide you guys more on the coming days regarding uh, mesenteric ischemia more from the general surgery slides. I know yet not fully clear, but we do have mesenteric ischemia, a lot of slides there actually. Uh, uh, yeah, but see, it's a D-dimer. I agreed with you, but in that case, they have to mention like a next test or something like that. Since that's best test, do you think? Uh, by the way, a handbook is okay, but handbook is also like a 14 years old. Even if you check the edition, there's no edition after last 14 year actually. So reliability, there is a word. So some question it is okay, but thing has been changed a lot actually in 14 years, my dear. Okay. So anyways, I think you can keep searching, or you can maybe ask me that question also in our inquiries on. I can give you the answer with a reference next time. Actually, it'd be more better. Actually, yeah. But as per the John Murtagh, in John Murtagh mesenteric ischemia section, they mentioned that your diagnostic test is a CT angiogram. Clear? Yes. So we're going for a break, guys. So thank you so much. We'll see you after the break. Thank you. All right, doctors, let me know in the comment section if you're ready. Okay. Yes. Little longer than usual, but we can finish in next 40-45 minutes. Okay. City scan is given. We had two, three question controversial, hence took a little more time. Sorry, everyone bought that city. 55 years woman and drinking, I think weight loss and persistent epigastric discomfort. What is the probable diagnosis? Her age is 55. Alcoholic, weight loss, epigastric. Okay, can it be esophageal cancer? No dysphagia. Okay. No mass. Nothing mentioned about bowel habit change. Bowel habit changes are common in these cases. Even though weight loss is a key feature, epigastric and weight loss can be close. At the same time, we have a alcohol history. Now it's between pancreatic and stomach. So if alcohol, if we talk about, I think it goes a little bit more with the pancreatic cancer, even though certain family history and this that can be very important actually. So we pick up pancreatic carcinoma in this case because more related to uh, your pancreatic cancer instead of the stomach cancer. Stomach cancer will have some other features which we discussed, I think, last time. One more thing, guys. I think now from now on, time to time, we'll be posting the handbook, like how to study the MC handbook. So I'll be uploading the question numbers regularly in our group so that like side by side, if you study, so it will be more easy for you. So this is GIT handbook. So do you prefer like studying the handbook separately or do you prefer to go with the class by class? I think it would be wise to go with the class by class from the handbook section actually. Okay. So I think for this reason, section 2 is a practical test actually given in the handbook. So the practical, the test, 8, then 10, these are actually numbers of that MCQ actually. Yes, respiratory I will also drop. No worries on that one, I think. So I think class to class, yeah, respiratory you also have to study at the same time. No worries, I can also do that. Just give me a second. Not about that. So what I'm doing, both respiratory, GIT, and the cardio. I think together I'm posting because eventually cardio is also coming up. So I think it's better I post all of them together. Taking one more second. Cool. So all these three just now posted. So I think as like all of you mentioned, I think we will post it class to class. Okay. So class to class, just open up this thing. The answers will be also you will find in the same handbook actually. MC Handbook is a MCQ based book actually, right? Even though it's a bit older, but references are helpful. 48 years, so men admitted to the emergency department, protracted cough, moderate fever. In this case, we have fever, interesting. But they do have central chest pain and regurgitation of undigested food particle most time, but does not suffer from any acid reflux. If does not suffer from any acid reflux, maybe you are not thinking about GIT or hiatus hernia. Symptoms been presented for last 3.5 months and which affects the food and drink now actually. Great. And chest X is showing acid air fluid level with a normal heart size. Interesting. What is the likely diagnosis? We don't have any focal neurological deficit, so I think that's out. Bulbar palsy, TB, not a recent traveler, so that's out. Uh, I think it's between achalasia and the hiatus hernia. These are the two things. These are the two close things actually. The word fever actually, honestly speaking, does not complement achalasia, honestly. Neither the cough, I think. Yeah. Already mentioned ZERT and the hiatus hernia, probably we are not thinking. Because but does not suffer from acid reflux. Okay. This one, I found it a bit controversial actually, honestly, as the time progresses. Mhm. Little bit confusing, but we ended up with a rare disorder with a LUC X-ray showing air fluid. Unfortunately, didn't mention about the lung abscess or anything like that actually. But what I understand from the pharyngeal pulse, there is a possibility of infection. That infection can lead there and can have the later air fluid level affecting the lung actually. So the pharyngeal pouch that is with some complication, it's a rare condition as you can see, sufficient disorder affecting the swallowing. So this is the explanation of the swallowing thing. It's like a traffic jam in the esophagus. Okay. So you can do the barium manometry and some other tests to rule it out actually. Okay. And of course, barium would be necessary in those cases actually. But the closest one here is a achalasia actually. Closest one here is a achalasia actually. But here the major thing that already fever, cough, and these things and probably this thing is affecting the lung with giving rise to air fluid level. Um, so that can be in pharyngeal pouch. So previously we haven't seen any question coming regarding pharyngeal pouch, but as a rare and a tough question, it has been given. And also we show you a barium already regarding the pharyngeal pouch, so they can ask it actually in your exam. Okay. This one, we cannot give you so much, I mean, interesting correlation and explanation like other condition, unfortunately. This one, you just probably have to memorize it at this point and do some more research on uh, these things. Maybe you can ask me one thing later. Doctor, can you tell us more about achalasia and the pharyngeal pouch? I can come with more better explanation, actually. Already those explanations are given. 50-year male, I think we have also short of time, died of cancer at 57, maternal auntie and colon cancer too. How will you screen them? I think screening related, I think we'll have a class or maybe already shared in the video channel in past in with the last batch. So we will guide you on that screening related class this time too. But this one, censored 50 and father died 57. So what do you think? I think we recently solved this question, I think, in the previous batch. This is colonoscopy every 5 yearly. How will you screening him? Best answer actually is missing colonoscopy now and every 5 yearly. We have also seen questions like that. So that is the best answer actually for this. Otherwise, I think colonoscopy every time is the right answer. Right. Coming to the next question, guys, we have to hurry up a little bit. Patients given amoxicillin, Genta, Metro, these particular things, where Clostridium difficile become positive, which we learned last day. Antibiotic associated diarrhea, it is called actually. Now, if it has become positive, maybe because of any reason, what is the next step in the management? I think high likely they are asking initial or next, whatever that one. I think oral metronidazole. Oral metronidazole. Is it oral metronidazole? What do you think? Or should we go for an oral vancomycin in this case? If since I think metro is already given, I think better answer would be I think going for a C should be the better answer here. Okay. So if metro is not there, my dear Vanpo, you can give oral, as per the John, like if you see vancomycin oral, you can go with. Okay. This line may be helpful. Yeah. So it's the oral one, just to be clear. 25 year, guys, we're not, if I keep giving explanation, class would be too long, I think. So I know you like conceptual things, but we have to be spot on for some next questions. 25 years and used to have asthma and child has CERD and taking this. It's an easy one. So let's go with it. The key line is here. Swallowing trouble is swallowing certain type of food, your diagnosis plays. I've mentioned the keyword. Right. A lot of people are going with B, C, D. It's a this one is the right answer. Okay. Any idea what is our diagnosis here? I think last day we talked about it. Eosinophilic esophagitis, right? Let me show that one. We had a discussion on that one. Yet I'm bringing it again. So it's a eosinophilic esophagitis. One of the treatment for eosinophilic esophagitis could be that using fluticasone, fluorinated corticosteroid, fluorinated corticosteroid. So you should also check the John method regarding that. Yeah. So fluorinated corticosteroid. So generally has relation with certain food. There can be other allergic disorder. Endoscopy can show other eosinophilic infiltration and buscopan, corticosteroid, even fluticasone. These particular things will be used actually. Moving forward, guys, I have to be faster. Sudden vomiting, dysphagia, epigastric pain, previous gastric fundoplication. So there is a procedure done, and going for investigation. This question I would consider a little bit more difficult for you guys. Okay. So this one, let me give you the answer. All right. We'll share the questions only. Okay. So here is a go. We go. We know we are going for barium solo. So here is the thing. after the procedure, this LABG, it's often procedure fund application procedure, LABG procedure is called. So if you have this kind of symptoms, like this, like severe vomiting, dysphagia, epigastric pain, so vomiting, uh, dysphagia, epigastric pain, then we go for a barium solo, guys. Okay, this one is a tough, so we are not going conceptual. So barium solo, this one is the procedure investigation. This barium solo. Next one. I think it's a repeat question. So I think the oral versus because metro is already been given actually. Metro has been already been given. Okay. So I got the repeat one. Severe ulcerative colitis, which presents with maybe acute flare of fever, tachy, and colonic issues. What's next step in the management? So it looks to me a severe ulcerative colitis with acute flare. Am I right? Ulcerative colitis, or let's say IBD cases with acute flare-ups. This is state actually. Okay, so we need to give IV steroid, and because of this particular thing is a red flag in these cases. So we need to give IV steroid so that some acute inflammation will be down and send for surgical consult because of this colonic dilatation. Now, intestinal obstruction, I haven't taught you guys in that way because it's a surgical thing. But what is the approximate diameter if it reaches that particular site? Uh, then you need to go for a urgent surgery. Like if you do an X-ray, and this is the dilatation centimeter mentioned. So final answer, any cases? Okay, tough one maybe for some people, 13 centimeter. If it is anywhere mentioned 13 centimeter or above, especially sickle part is the bigger part. So in that cases, that's like a direct red flag, direct surgical indication. I'll teach you that one more in the general surgery someday. Right. Clear? So this colonic dilatation is probably a red flag. I think in the main exam, they will also tell you about the size actually. Right. So this one is probably an indicator of toxic megacolon. So we definitely need to measure the size. Following ulcerative colitis, it is quite a common. Did you know this information? Toxic megacolon is a complication of ulcerative colitis, whereas fistula, abscess, obstruction are features of Crohn's disease. Did you know this information? I hope so you do. Wonderful. Again, a conference mail. Last day, I think I show you this question. I'm not very sure. While teaching the theory with a forced vomiting, suddenly pain in the retrosternum. So this is the only one question available so far. It has came. Nothing different has came. So this question I've been, I think you might find in our old slide as well because nothing different has came on this one, but it is important. Anyone can guess what is the diagnosis of this one? Yes, if you are thinking, this is the Boyer herpes actually, one of the esophageal complication, esophageal emergency. Am I right? Am I right with the choosing the word? Like Boyer herpes. Boyer herpes has lateral chest X-ray. Boyer herpes having lateral chest X-ray. In past we have shared, I think this one. Boyer herpes having lateral chest X-ray. Why? Because often there can be underlying pneumothorax, correct? Often there can be pneumothorax and the lung collapse can be evident. So you need surgical repair, but even though mortality rate is very high. So Boer has high mortality, even though if you do a surgical procedure. Remember last day. Remember last day. There's nothing mentioned about atrial fibrillation or MI following. Yeah. So in that way, plus embolic things actually, and also flexures of the colon has to be mentioned actually. But it's a good DD. If you think about mesenteric ischemia, it's a good. 40 years patient travel to the Indonesia. See, travel related things you will find on and off in the main exam. Central abdominal pain, which turns on to another side. Now she has diffuse abdominal pain, no sign of beta irritation, otherwise examination normal, except painful diarrhea, which is a common cause of her primary symptom. All right. Come on, guys. Okay, so I'm saying appendicitis. Hmm. Now, how many of you just now received a bamboo here? Thinking that it's an acute appendicitis. Now, we tell in fun way as a bamboo. Bamboo is in Bengali, it's called vash, We use it in funny way. Quick question, painful diarrhea, is that anywhere a finding of appendicitis? Is 100% no. Painful diarrhea rather than can be a finding of the Crohn's disease because Crohn's disease having them affecting the rectum and canal. So it's quite evident actually, or inflammatory bowel disease cases. So D both can be right answer if you have chosen, but more specific is Crohn's here actually. Ooh. You remember, I hope, about the complications and this particular site. This slide is very, very helpful. Other than the John Moore type, this slide must be, yeah, all right. Painful diarrhea is the key finding here. Same thing. Inflammatory bowel disease is the general term, but we have a more specific term, so we choose the more specific term. My dear, this is AMC. They will do whatever they want. All right, great. Okay. Patient with esophageal varices and repaired, and again comes with bleeding, which approach. Guys, I don't have that much time today to explain more, so let's go a little bit more faster. Okay. So, what do you think about this one? When I said esophageal varices, like lower end of the esophageal bleeding, which has been previously repaired twice. Very dangerous condition which mortality is not good. Normally, if you do any procedures, it increase the, you know, hepatic encephalopathy. Okay, hepatic encephalopathy, I haven't taught you guys it, but in any ways, this question popped up here. Hepatic encephalopathy chances increases with surgical procedure, electrolyte imbalance, shunt procedures, and this that. Now, one of the shunt it has been or a procedure has remarkably uh, reduces the encephalopathy chance. Now, the question is which one is that? In answer, some people are choosing TIPS because you only know about TIPS. TIPS actually is a classic shunt procedure that increases the chance of hepatic encephalopathy. Like means more chance of hepatic encephalopathy. Yeah. So final answer we are going with is a splenorenal shunt, which is also known as a Warren shunt. A little bit surgical question. So distal splenorenal shunt or Warren shunt. Do you guys understand that we have to level up you know, what we have. Like maybe how many of you never heard about this name, Spinal Renal? I think many of you, I guess. So it's normal here. Uh, so those of you are thinking that, okay, I just finished MBBS, so I don't have gap. Yet you need to learn a lot more actually. Answer for this one, spinal renal shunt has least chance of hepatic encephalopathy. Guys, I know you guys like conceptual thing study, but everything is not conceptual. Few of the thing stat based actually. Like Dr. Jalal, I can say asking everything as a counter question. I mean, maybe need to increase the knowledge level a little bit more with due respect actually. All right, great. Next one is a 18 years with a bloody diarrhea. You made sigmoidoscopy with a 10 centimeter fiber mucosa. Now, this is supposed to be easy question because I have mentioned it. If I didn't mention it in past, it could have been a tough question for you. So area of friable mucosa, which I think I have mentioned in the classes. That's why the class related every single thing you need to mark actually. Now this one is going towards with the bloody diarrhea towards the ulcerative colitis. And we have mentioned this one, ulcerative colitis. Now, guys, some of you are consultant level and they think that they know too much. I respect that you know your field too much, but MC is quite a difficult. I've seen many consultant fail, in the exam, and I saw many youngsters they pass all the time. It is one of the reason is you have to be very persistent in the classes, and some of you, because you're a consultant, you just hear while using a mobile, you guys don't take notes, and later you guys forgot those points actually. So it is very very important, guys, you have a study partner, study group, and take all the class points actually, because these things is going to come in the exam. Not always day to day what we use in the practice based questions are less, instead of AMC based questions are more here. So here is the thing, this question answer is a sulfasalazine. The diagnosis is ulcerative colitis. Ulcerative colitis and sulfasalazine, if you remember. And special line which is not mentioned in John Mota, but I took it from some of the other slides which I have shown. So area of friable mucosa. So area of friable mucosa. Okay. Diagnosis, ulcerative colitis. Treatment, sulfasalazine. Because why? They ask initial. Young man trip 2 years back, mucus and blood in the stool, and again and again, back to back episodes. So, what is the diagnosis? Guys, please focus on the class, please. Focus on the given task. So, there is like a remittance, remission, and this kind of thing. I think we have already solved this one. So, this one is resolved as ulcerative colitis. Child with increased vomiting, 3 days, night symptom, not gaining weight, cheerful, happy. I think this one is solved as a ZERD. This one we solved as a, I think, ZERD. So milk flows freely from the mouth. Already we have discussed this part with the ZERD, not going there in details. Okay. 55-year man presents to your clinic complaining of recurrent abdominal pain radiating towards the back. Please highlight this point, radiating towards the back. Please note I'm also tired, so I might also freak out at the end. Okay. So no specific trigger is mentioned, and pain does not seem to be related to eating or hunger. The good news is ECG is normal, abdominal pain, and ultrasound is inconclusive. Laboratory tests, including all these findings, are normal. Amylase, lipase, troponin. Following condition is most likely diagnosis. Some going with A, some going with D, some going with C. A keyword is a 55, a recurrent abdominal pain. So it has been happened before and radiating towards the back. Now we have to find out which of the following usually can radiating towards the back. I think it's a common with the pancreatic pain, which is radiating towards the back. Now this can confuse some of you mentioning um, these parameters are normal. Yeah, that is the thing. So because most of you came from, this is more like a practice related question. Amylase lipase things can be normal in early stage is given you a clearance for it's not pancreatitis. Amylase lipase things are normal in the beginning. Is that a indication it's not a pancreatitis? Troponin I ECG is normal in the early stage of heart attack. I'm comparing and contrasting. Is it assured that it's not a heart attack or MI? This is a same kind of question like that. This can be a devastating condition, the pancreatitis, heart attack, all these things. So you cannot take chance. Serum amylase lipase, very clearly mentioned, can be normal in the early stage. Very practical, very practical question. I like it. I received some patient even like that in my life. But so those I'm remembering now. So how practical this question is actually. All right. So this one is a pancreatitis. Because your keyword or chief complaint is a recurrent abdominal pain radiating towards the back. Pancreatic pain can be often recurrent because it has happened slowly, leaking, slowly something is happening. Okay. Also, pain is lasting for some hour. That is also interesting. So certainly cardiac thing also should be excluded at the same time. Yes. Right. So since radiating towards the back, this gives rise to pancreatitis. Pancreatitis. Now, some people ask, doctor, can it be cholecystitis? Cholecystitis pain, it can be like upper abdominal pain radiating to the tip of the shoulder. Am I right? Radiating towards the tip of the shoulder. Okay. Very classic question for pancreatitis. For pancreatitis, there can be in future more questions. I will guide you guys in future during the surgery. Pancreatitis, and there is another one, pancreatic cirrhosis. These two conditions, if you can, no pressure. If you can, read in little advance. I brought this one because abdominal pain is a part of the GIT. Abdominal pain is a part of general surgery. Abdominal pain is a part of the gynae as well, even pediatric as well. Right? Great. So it popped up. That's okay. But pancreatitis and pancreatic pseudocyst are more popular for you in the exam. Also, pancreatic cancer, some cases. All right, you have been investigation with ZERT or ZORT, comes with upper GIT bleeding, H. pylori positive. Now you control the bleed, but 8 of the ulcer are still bleeding. Okay, what is the next step in the management? Yes, please. This is something from the syllabus which you have discussed with us. Okay. I'll be very disappointed when some people with their answer. Okay. Please answer everyone. So some people answer this I saw immediately jumping. That's what I'm saying. This is not about my dear, just showing that you can answer first. I saw three, four, five people in the beginning quickly answered triple therapy. Oh, that's a H. pylori positive. Okay, triple therapy. My dear, still it's a bleeding. So isn't it your first job to control the bleeding? Otherwise, your patient will die. Peptic ulcer, H. pylori, you can treat later. So here is the main thing, injection adrenaline. So injection adrenaline is done as per the John Mukhtar, injection adrenaline already mentioned very clearly last day. I've mentioned to give emphasis on that one, injection adrenaline one. Okay. This is the one recommended. Bleeding peptic ulcer must be focused treating the with the injection adrenaline. As a support, you can also go with the uh, omeprazole. So that would be a supportive. If you don't control the bleeding and only go with the IV omeprazole, you will be ended with a hemodynamic unstable condition. All right. I recommend 2, 3 doctors checking the answers to study a little bit more deeply after the theory classes because certain things have been mentioned. And what they do, they are usually some of them are consultant, just come to the classes. During the class time, they check it. They thought it's done, but it's not. They don't remember, and in the next recall class they came and then again asked the same. You guys realize, right? I mean, by checking some of them's answer. So just keep asking the same thing, which we already discussed very clearly in the live classes. So I'm not criticizing, but just go a little deep down into the study. Consultant doesn't mean nothing will happen in MC. You have a disadvantage being consultant in MC part one. Maybe when you pass the exam, you have an advantage being consultant, but the passing will be a disadvantage for all the consultants here. I'm telling you that one because you have a job separately. Some say, "Oh, now I'm joining a class using a mobile." I mean, should I clap for that? Not really. You should manage that one here. All right. So I'm very straightforward with my job. I take my classes very sincerely. I own 5 6 different companies, but I'm never late with the classes. I'm always in time. You'll find. I update myself. I study whenever necessary. So you can also do your job. You have a one job only like a medical practice, which I also have, but I have a gym to run. I have some other shipping companies and this that. In spite, I do everything. So it's all about my dear time management in life. Okay, you can do it. I'm just telling that you can do it, nothing else. Okay, old men with a low calcium and other blood lipids and more. What is the cause of a low calcium? Now, sometimes one to silly questions you will get to see in the MC exam. But what do you think uh, about the cause? I think it's a easy one, but this easy ones does come in the main exam. Okay, so this easy ones also does come in the main exam. Right. So this is nothing but dietary deficiency. So I'll give you example of some of the similar question that is tested. Dietary deficiency, iron deficiency anemia, nutritional deficiency. Like often iron deficiency anemia scenario given, and then they ask it's because of the diet and nutrition. It is true. Same thing here. Again, the dietary deficiency. All right. So this kind of question you get to see. And another one you will find vitamin D deficiency related questions. Like a kid from the Sudan is often given uh, Asian people. So it can be again vitamin D deficiency some cases. And some cases there's another this looks silly, but it's a so common in a lot of people. So dietary deficiency it can be because of low calcium, low vitamin D, and this that actually low iron. Yeah. Yeah, it's nothing reference to give about that one. I think we know it. Yeah. Uh, Last question before, so we'll be going up to question 40. Periumbilical pain migrated into the right iliac fossa. Okay, now that looks classic anorexia. What is the next best step? A bit surgical question. I can give you a lead. So, what to do in this particular case? Okay, we cannot wait for 72 hours to this thing can burst. So I think definitely what you can go for in full assessment. When you clinically examine, you might find um, some other signs positive. Okay. Let me tell you one thing. This is also an MC question in past. What is the uh, most surest sign or number one clinical sign for appendicitis? Any idea, any cases? One of the key clinical feature of this. Close one more, please. Rebound tenderness. Yes. Rebound tenderness is the most confirmatory clinical sign. Well done, guys. Rebound tenderness. Okay, so this is one of the thing which I will teach in the surgical class, and so as the many other things in come in the chest pain. But in the surgical acute appendicitis, acute pancreatitis, diverticulitis, cholecystitis. This one you can take a picture, by the way, but you can also check if you want in an advance. I never forbid you to study things in advance uh, because in first 2 weeks are almost we are doing. I think you guys are becoming more mature now. I think tomorrow I will be sharing the question bank with you the in the group. So definitely, you will have your question bank that time. Downloadable on question bank I'll give. So definitely you can do that. And as for surgery, you can also check from the note. If you want to study in advance, I don't mind actually. No problem on that one. If you can manage, some people study like crazy. 12 or 14, well, I appreciate that actually, because your future is visible and clear, or probably you have time actually. In spite, some people have time, but they don't study that a lot. If you can, please do it. Please do it. Study. So normally, how much we recommend actually? There's the old classic things. What you mentioned when you come to the SMA Shares Medical Academy, 5 hours a day, 5 days a week for 5 months. This is the minimum actually. This is something minimum, but it has to be productive and continuous. It's not like you just open the book and sit continuously. That doesn't mean it will work. I mean, okay, yeah, a lot of tips will be given. I mean, 5 months, what I will do that. Yeah, don't worry. So much tips I'll give you guys. Which of the following is the first test that should be performed in a patient with a lower GIT bleeding? Lower GIT was included even though surgical mode, some rectal conditions, but lower GIT bleeding causes we have mentioned diverticulitis, angiodysplasia, hemorrhoids, anal fissure, rectal cancer, many things. You will probably get fresh rectal bleeding. Yeah. So, what do you think? So, one test if you want to do in that case should be CD, CD, CD. Okay, that's like controversial, even the proctoscope, because not everywhere you can use proctoscope, like Fisher, some of the other conditions, like yeah. But colonoscopy is universal, I think. So maybe it can be a little tricky. Yeah. First test you want to do, I think it's more we like to go with the colonoscopy for lower GI plate. Okay. Next page we have some information. Um, One thing is given lower GI bleeding. Um, Resume this part. This is the last question we're dealing, so you can chill now. Lower GIT diverticulosis, lower GIT angiodysplasia, which is vascular. Of course, cancer can happen. Rectal cancer, fresh rectal bleeding, inflammatory like IBD, and this that IBD cases again you cannot perform the proctoscope, right? So as the anal fissure cases. So most common cause of lower GIT bleed is infants. Interesting, anal fissure most common lower GIT bleed in children can be polyp. And yeah, this is some extra information. And most common cause of lower GIT bleeding in adults, diverticulosis. Second most common, angiodyspepsia. Then comes hemorrhoids, fissure, and all these terms actually. All right. These are in generally all the causes of lower GIT bleed. Generally, all causes of lower GIT bleed. Okay, which we have discussed. You need colonoscopy eventually for these particular things as a test. Great. So, guys, thank you so much. I guess maybe that's all from today. And yes, this I think class related question file will be posting soon. And good luck to all of you for attending a long session. Sorry about that because we had two, three very much controversial question. So I had to give you some time for that. Yet there will be confusion, but we do have a GIT inquiry zone. I highly recommend. Please, guys, do ask me question. I'm very happy to answer those questions. Actually, I feel more happy uh, if someone asks those questions. So here is the thing, a GIT inquiry. If you just scroll down a little bit, because now you remember where you had that confusion, and then please do ask me that question related explanation. I'll be definitely answering you there in that. My messenger chat box always is not controlled by me. It's my team around the globe. People text me, so of course team handles that often. So and feel free, guys. I mean, asking this thing, GIT related things in the inquiry zone. Trust me, with the time you will just get better and better and better. You will be fine. You will be a doctor in Australia. Just you have to have that faith with the time. Thank you. Good night and good luck. And lastly, sometimes we tell few tough words so that you come to in our space actually. So anyone, please do not take it anything by heart actually. Good night again.